Yeah, and just wanted to know when you want to start off. Do we start?
Yeah, please do.
Yeah. So since it's already, I think it's just touching. Maybe we wait another minute till some more people join in. I think there's 33 I can
And maybe, yeah, and maybe you all could speak about something very clever and metabolic, which the rest of us don't understand.
see.
I was basically, do I need to have control of the meeting because I can't seem to share anything?
That Miss Chetana is the representative from ORDI. Miss Chetana, can you make Dr. Gauri the host?
Okay, ma'am. I make Dr. Pawan as a host. I'll change it to Dr. Gauri.
Sure.
Yeah.
I can't
Thanks.
see Dr. Pawan here. Dr. Pawan, are you there?
Yeah, ma'am, I'm there.
You're there. Okay, then. Okay, it was your. Okay, can you shift over? Shift over control.
Yeah.
Oh, there's lots of familiar faces. Dr. Arijit. Hi.
Hi, hi, Anne.
Hi, it's very nice to see you here. Happy Christmas.
Merry Christmas.
Okay, I think we've got plenty of people, and it is
Yeah.
8:30.
Yeah.
So maybe it would be good to start. I think it's a privilege because Gauri has the advantage of knowing both genetics and metabolic medicine and having practiced both. I think the viewpoint from her angle to look at metabolic myopathies should be useful to all of us, you know. So Gauri, I don't know if you want to start off.
I'm just trying to figure out how to share my screen because although it says I can't seem to do it for some reason.
Maybe if you log out and log in again.
You must be able to share now, ma'am.
Yeah, let me log out and log back in
Okay.
because that might be the problem. Just bear with me a second.
Is Gauri having problems joining again? Gauri, any luck with your slides? I don't know if Gauri is there. Dr. Pavan, are you able to help her get
Yeah,
her?
ma'am. I'm trying to contact Dr. Gauri, ma'am. Just a minute.
Yeah.
Hello.
Can you hear me now? Sorry.
Yeah,
Hello.
we can hear you.
Oh, this has been sorry, it's been a bit of a that's the one. Can you see my screen?
Can see your screen? Yes.
Okay. So I'll make a start. Sorry about all of this. So I'd just quickly like to thank Dr. Anne and Dr. Bhatt for presiding over this, and for allowing me to do this, and obviously the ORDI for giving us this platform. So my name is Dr. Gauri Krishna. I've recently relocated, and I've just joined Dr. Anne at her workplace, and I hope to join Dr. Bhatt at some point in the future. So without further ado and wasting anyone else's time with all of the stuff that I had to do in the background, we'll start off with metabolic myopathies. So as I was uniquely placed in my training, I could do both inherited metabolic disorders and genetics. It was a great overview in terms of how to manage people and actually go down to the level of genetic counseling. So the aims of this talk are to look at, first and foremost, determine clinically the most likely affected biochemical process, identify which patients should be investigated further and by what methods, separate those that might have a genuine metabolic myopathy from those with other conditions, like with a pseudometabolic mode of presentation, and identify those patients with conditions for which there are pharmacological and or other treatments available. And that's the key to this talk, really. So just a brief introduction. So metabolic myopathies are a subset of the inborn errors of metabolism that disrupt enzymes necessary for metabolism of carbohydrates and lipids. And like all metabolic conditions, it results in energy failure. Now, the symptoms can involve multiple organs or be limited to skeletal muscle, resulting in exercise intolerance with or without rhabdomyolysis. And the age of onset varies very greatly, and it spans from infancy to late onset adult forms. The severity of symptoms correlates with residual enzyme activity, and that's really important to remember. The greater the disruption in enzyme activity, the more severe and earlier onset are the symptoms. So individually, specific metabolic myopathies are rare, but as a class of inborn errors of metabolism, it's very likely that you would encounter these patients. And they would complain of, and the symptoms that can be very non-specific, like fatigue, exercise intolerance, myalgias, weakness, cramps, and they're very non-specific. So sometimes they are attributed to laziness, growing pains, and sometimes psychiatric disorders as well. So it's really important that we are able to support these patients and identify them correctly because treatment is available for quite a few of these conditions. I thought we'll just briefly touch upon both muscle energetics and biochemistry, just to take this talk forwards and to assimilate it really well with what we are trying to learn. Sorry. So basically, the most important thing that I think about is we all need reserves of energy. We can't constantly be eating. So when your nutritional uptake is discontinuous, you use your available reserves. And here you have adipose tissue and liver and muscle. So in the form of triglycerides and glycogen. And these are important in biological functions. Now, nutritional uptake being discontinuous, when you have reserves and you're much older, it's not such a problem, and your biological functions are still maintained. And that's why complete disruption of enzymatic activity in newborns, where they don't have reserves and their nutritional uptake, if it's discontinuous, we run into big problems, especially in form of metabolic crisis. So this is a general overview of what happens. I'm not going into a lot of details. This is just a very quick understanding. So proteins break down into, so everything finally culminates into going into the Krebs cycle and producing ATP. So you have the breakdown of carbohydrates, lipids, amino acids, all of them go through different pathways. But both proteins and carbohydrates, as well as fats, they all sort of culminate on acetyl-CoA, and then you form ATP. So that's like the basic overview. Looking at the muscle energetics, this is really important to understand. So the transition from rest to exercise uses immediate stores of ATP, which are available for 10 seconds. So that's your stored ATP. Subsequently, you've got glycogenolysis, which is the breakdown of glycogen, which is activated. And anaerobic glycolysis, that's a breakdown of glucose, provides a rapid but very inefficient process of ATP production with lactate as a byproduct. Then high intensity exercises such as sprinting or lifting heavy weights, they rely on anaerobic glycolysis. And within minutes of submaximal exercise, oxidative phosphorylation, that's via the electron transport chain, becomes the primary source of ATP generation. And this initially uses glucose from intramuscular glycogenolysis. In this early phase of exercise, or with high intensity activities, the disorders of carbohydrate metabolism are unmasked. So that's really important to understand. So glycogen storage diseases, which have an abnormal accumulation of glycogen either in the muscle and or liver due to enzymatic deficiencies in glycogenolysis, glycolysis, or glycogenesis will cause this problem. Now, with continued exercise, the specific metabolites used for ATP generation that depend on intensity and duration of exercise, you have free fatty acids, which are the predominant source of energy. So low intensity and long duration aerobic exercises rely on free fatty acids. And as the intensity increases, a greater contribution from glycogen is necessary. But glycogen, again, is a limited source of energy. So limitations in oxidation of FFAs will result from disorders of lipid metabolism, and that includes enzymatic defects necessary for fatty acid oxidation or the carnitine cycles. So this is the sort of basic underlying physiology and pathology that we would encounter normally in metabolic myopathies. So when do we suspect it? Sorry, I just have a bit of a cough, residual cough. So when you have exercise intolerance and fatigue, as was obvious from the muscle energetics, if you have episodes of rhabdomyolysis, because of muscle breakdown to make energy, because you don't have the other sources of energy available, episodes of pigmenturia, symptoms arising after periods of fasting, or so that's another important one, and prominent myalgia, cramps, and stiffness. Of course, if there's consanguinity and affected family members, that would raise some red flags as well. So the first one we discussed were all the enzymatic defects along the pathway of usage of glycogen storage, and that would be our first port of call. So we'll just go through a few cases and then decide how best to manage them and what treatments are available. So this was a 25-year-old male. He presented with type 2 respiratory failure to the Neuromuscular clinic initially. And he had a 3-month history of increasing tiredness and drowsiness and had been found to be hypoxic with marked hypercapnia and an elevated serum creatine kinase. Past medical history, the only thing that was significant, and that was in retrospect that we looked back, he had delayed motor milestones as a child and that he had struggled with sports. And he came from a very sporty family, so this was picked up. On examination, he had significant paraspinal and periscapular muscle wasting with hamstring, calf, and anterior leg muscle wasting. At that point, he had a muscle biopsy, and he was presumptively treated as polymyositis, although he was seronegative, and he was started on corticosteroids. He was also started on BiPAP, and that seemed to improve his respiratory profile. But he continued to have, so we brought him back to clinic, or rather he was referred on to the metabolic services at that point for another opinion. He continued to have significant fatigue and deterioration of functional motor assessment. And at that point, we had the report of the muscle biopsy, which showed accumulation of glycogen with membrane-bound vacuoles. You can see that here. So this is the HE staining. And in the PAS stain, you can see this. And this is just an ultrastructure under microscope where you see increased number of lysosomes. So at that point, we sent off for genetics as well, and a genetics confirmed diagnosis of Pompe disease. And in this case, it was late onset because he must have had significant residual enzymatic activity. So just moving forward, I just wanted to touch upon GST is a whole topic that we need to cover separately. And I thought that was not going to be possible. So I thought we'll just focus on things that we commonly encounter within the GST family, more common than the other GSTs. Special reference to GST 5, 7, and 3. So GST 3A and 3B can be quite common, and they're the debranching enzyme deficiency problems. It's here. And in the myopathic form, so you have the liver form and the myopathic form. In the liver form, you can have lots of involvement of the liver with cirrhosis and hypoglycemia when they were infants. Excuse me. In the myopathic form of GST type 3, the usual presentation is usually in the 3rd or 4th decade of life, and they have distal limb muscle weakness followed by proximal muscle weakness, and there's slow progression. The other one I wanted to mention was GST 5, which is McArdle. And the one thing that we always see with McArdle is the clinical hallmark of this disease, the second wind phenomenon. It's been studied quite a lot. Basically, in the first 15 minutes, patients experience progressive fatigue and weakness when exercised quite vigorously. And there's an adaptation phase with rapid and complete recovery. Following this, they're able to continue exercise without difficulty, and that's the second wind phase. And the reason they have recovery in the adaptation phase is we think there's increased cardiac output, and free fatty acids come into play in terms of allowing the second wind phase. So this is quite important. So very often what happens is, I think the way things happen is they present to the neuromuscular clinic. They have a lot of investigations, including neurophysiology, and that's quite good in terms of trying to find out a proper algorithm as to where to place them. And then lots of energy exercises are done. So before they used to do the ischemic forearm test, now it's not done. But the non-ischemic forearm test is also something that can be used in practice, but I don't think it's very commonly used. I think everybody now goes directly to get genetics or in the worst case, maybe a muscle biopsy after neurophysiology. The other one I wanted to mention was GST7, and they may present not only with progressive muscle weakness, but also involvement of the liver, heart, and CNS. And the neuromuscular involvement can be very variable. It can be quite severe in the neonatal period with hypertonia cardiomyopathy, and you can have later onset, which is similar to other myopathies where you have rhabdomyolysis, muscle cramps, and so on and so forth. And you can also see hemolytic anemia with this particular group. Sorry. Was someone asking me a question? I will just stop for a second. No, I'll continue. This is a brief look at the myopathic sort of picture in GST. It's very big to cover, but I think if we keep thinking about it, that's really good. And that would be a great place to start, because at least GST5 and Pompe disease have treatment. Not excellent, but treatment is available, and it's worthwhile considering these conditions in the first instance. So next, let's move on to sort of the respiratory chain bit of myopathies. So this is another case, a 62-year-old male, swollen, painful leg, dark urine, low-grade fever. CK was markedly increased, and he was also diagnosed as viral myositis. He had a follow-up in neurology clinic where he was noted to have worsening bilateral ptosis, complex ophthalmoplegia, and sensory neural deafness with past medical history of diabetes. And that triggered the neurology registrar, who immediately sent off mitochondrial panel and also requested a muscle biopsy. So the muscle biopsy identified excess COX-negative fibers, and it suggested a mitochondrial disorder. The initial mitochondrial DNA, the genome that they did, we didn't pick up anything. So we did a long-range PCR, which did show evidence of mitochondrial rearrangements. He was trialed on ubiquinone at that point. So these are two of my favorite diagrams to depict the increased mitochondria using the GT histochemical stain. And that's a really nice one, especially where the arrows point. And basically, mitochondrial DNA and STH, which is encoded by the nuclear DNA, and that helps even with the genetic process. I don't know how clear this graph is, but this is one of my favorite graphs, especially when you're looking at a patient with progressive muscle weakness and exercise tolerance and hypercemia. So whenever you think about muscle disorders, or when you're thinking about GST categories, it's important to think of them as primarily episodic, exercise-related, primarily fixed, progressive. Is there cardiac involvement? And do we think there's a partial metabolic block or a complete metabolic block, or do we think it's lysosomal, as is the case with Pompe disease? So this is really critical in sort of understanding what would be the best way forward. But I would appreciate that within a resource-poor setting that we need to be smarter and we need to be more sensible with how much money we can spend for the patient and still get to a definitive answer. So I think when most of these cases present to the neuromuscular clinic, and this is a really good way to look at things. So you do neurophysiological studies, see if there's myopathy with myotonic discharges or without them, and whether they're neuropathic changes, whether it's normal or if there are NMJ alterations, which is a completely different thing. And those are your pseudo-metabolic myopathies, and that we will just briefly touch upon later. So if you've got myopathy without myotonic discharges, you want to check GA activity on DBS. That's what we would do normally there. But obviously, if that's the case, it just probably makes sense to sequence the GAA. I'm still getting used to all of the pricing, but I don't know which would be easier. And probably Dr. Butt can tell us if assays on fibroblasts for GAA are available now or not. So I need to really get updated with what's happening. I'm sure lots of things are happening, but of course sequencing would be probably an easier alternative. And then there are other things. Everything sort of comes down to either doing a muscle biopsy or looking at enzyme studies or molecular genetic studies. Sometimes genetics doesn't give you all the answers. You've got lots of variants of unknown significance. So it's great to have a functional backup in terms of looking at enzyme activities. So that's really, I think, where we need to focus on in India in terms of getting better answers when we have VUSs on genetics. And of course, you've got the whole sort of spectrum where you look at whether you've got polyglucosan body disease, vacuoles without increased glycogen, with or without increased glycogen content, COX fibers, rag-red fibers, and of course, lipid storage. So moving on to another case. So this is a 26-year-old female. She had episodes of rhabdomyolysis triggered by exercise. Her serum creatine kinase was around 59,000 units. She had past history of exercise-induced myalgia and myoglobinuria for a few years, and she was very fit and active. And her myalgia usually happened around 40 to 120 minutes into exercise. So if you remember your muscle energetics, and then would persist for days afterwards, and there was no second wind phenomenon. So this was really important. Examination was normal, and a free carnitine and acyl carnitine profile was abnormal, which we will look at. Similarly, we had another, so this is the other end of the spectrum, so a 3-year-old admitted with fever, cough, and dyspnea. She had influenza, bronchopneumonia. She had an abnormal renal function with raised creatinine, SGPT, and SGOT. And because that was increased, she had a CK done at that point, which was elevated, very elevated. So at that point, she had some investigations as well when she was acutely unwell, and she had an abnormal acyl carnitine profile. We sent off skin fibroblasts and genetics at that point because mom was planning another pregnancy. So this is how an acyl carnitine profile gram looks. And what we see here are peaks. We see peaks of C16, C18, and an increased ratio of C18 to 1. So this then sort of told us that, you know, with the history, it looks like we're dealing with a fatty acid oxidation defect. And just very briefly with the fatty acid oxidation defects, the other additional presentations you can have are neonate with cardiomyopathy, hepatitis, hypoglycemia, or an infant with liver failure, an adult with retinal degeneration, rhabdomyolysis, and peripheral neuropathy, or if you had maternal liver disease in pregnancy with AFLP or HELP. So these should definitely trigger something, and we should be looking at fatty acid oxidation defects or metabolic myopathies. So this is basically what happens. So they go through this really, I call it the coil method, where it just goes through cycles and cycles, and that's beta oxidation and produces energy, and they go in freely. So what would be used for movement is carnitine. So that's a really important one. So you've got CPT1, which is in the outer mitochondrial membrane, CPT2 in the inner mitochondrial membrane, as well as the translocase, which allows carnitine to be shuttled in and out of the mitochondria. So that's in the cytosol, and that's in the inner mitochondrial membrane. So this is a really nice graph that I usually use to sort of give a brief overview as to what we're looking at. It's much more difficult to diagnose CPT2. And for that, we often use skin fibroblasts to do fatty acid oxidation flux studies, because very often we don't find mutations, but the picture fits in very classically with CPT2, especially in the younger ones. So this is another case, a term baby, female, non-consanguineous family, started grunting at 4 hours of life. She was hypoglycemic. Thankfully, a screen was done, and she was noted to be non-ketotic, which is again another clue, because this is really important, this formation. So if you've got non-ketotic hypoglycemia, it again points towards a fatty acid oxidation defect. She also had metabolic acidosis, and she looked quite dysmorphic at that when she was examined. She had a high forehead, low set ears, wide spaced eyes, a small mid face. She also was noted to have kidney dysplasia and kidney cysts, which were done much later during her admission on NICU. So this is another clue where you have got dysmorphic baby, metabolic acidosis, non-ketotic hypoglycemia. So you're thinking about a fatty acid oxidation defect, but you're thinking about something different in this case. So another case, the other end of the spectrum, 22-year-old female. She came to the emergency room with anorexia, vomiting, and nausea in the past month, which was associated with a significant reduction of food intake and weight loss. She was trying to lose weight, so she was really struggling, but there was no history of fever reported. She was quite confused when she came in. She had pulmonary breathing pattern and a fruity breath odor. She had metabolic acidosis with an elevated anion gap with a normal lactate level, and her blood sugar was 55 milligrams per deciliter. I had to convert this, so I think it's around this, but it was low on measure when it was 1.8 millimoles per liter. So she had a lot of investigations. She had urine organic acids when she was unwell. She had abnormal peaks in lactic and glutaric aciduries, with a large number of other hydroxy and dicarboxylic acids. I didn't have that pattern, or rather I had the pattern, but the name was there, so I couldn't get rid of the name, so I don't have the pattern to show it here. She also had low levels of free carnitine and elevated levels of C14 to C16. And you can see lipid storage in hers, both in H&E staining and PAS. So this was the other sort of thing you would encounter in clinical practice, acute episodes of exercise intolerance, contractures, hypercemia with myoglobinuria. So again, you want to look at what were the triggers? Was it strenuous exercise or infection, cold or fasting? Whether there were any signs of hemolytic anemia. And then, of course, the forearm exercise test, I don't know how feasible it is to do here, but basically you would look for a low lactate and high ammonia after an ischemia test of the forearm. And that would trigger a metabolic myopathy. So, and then you would look at, looking at the serum lactate, acyl carnitine profile, urinary organic acid, and again, whether it's normal or abnormal. If it's abnormal, we're looking at whether it's a long chain, very long chain, medium chain, or if there are multiple chains in your profile. So the multiple chains, so this particular profile of both these patients was a multiple acyl CoA dehydrogenase deficiency, which is riboflavin responsive. So that's really good. So we can have, so just very briefly, I wanted to touch upon what are the mimics. So this is probably your forte, not mine. So you can have lots of problems with LGMDs, dysferrinopathies, sarcoglycanopathies, fukutin-related protein deficiencies, of course, Becker's, as well as autosomal dominant RYR1 mutation, myotonic dystrophy, and always to do with thyroid and vitamin D. levels. And I think one of the things that we need to think about if we think it's metabolic myopathy is if you see seronegative polymyositis. And just as an algorithm picture, which I think I forgot to mention here as well, was whenever you're thinking about clinical features of metabolic myopathies, you want to differentiate between GSDs and fatty acid oxidation defects. Sometimes these algorithms may not really make sense, but if you just sit down and think about exercise intolerance context, glycogen storage disease is usually high intensity exercise, exercise-induced contractures, whereas fatty acid oxidation is low intensity, long duration exercise and exercise-induced pain and stiffness. Then think about strength. Exercise-induced or fixed proximal weakness is seen in glycogen storage disorders, whereas exercise-induced or fixed proximal weakness is seen in fatty acids. So strength is quite a challenging one to look at. So that would not be your great one. But I think it's good to document which areas of weakness you're noticing. The other features are second wind or out of wind phenomenon that you would see in GSDs. And in fatty acid oxidation, you're thinking about rhabdomyolysis triggered by fasting, illness, or prolonged exertion. Baseline CK could be normal or elevated in GSDs. Usually in FAOs, they're normal if they're fine, there's no acute crisis, especially in the older patients. EMGs can be, again, very difficult to differentiate. They could be normal or myopathic. Of course, the next step is think about muscle biopsy, which may not be feasible every time here, but where again you're looking at increased glycogen stores on PAS and electron microscopy. Sometimes it can be normal as well, and the same holds true for fatty acid oxidation defects. So I think those are the most important sort of aspects of looking at differentiating these two conditions, predominantly, which you would see presenting in clinic. So what are the general principles for treatment? Very simply, avoidance of trigger factors when you're looking at fatty acid oxidation defects, reduce load on affected pathway, which may not always make sense with glycogen storage disorders, emergency management in acute illnesses, very true for fatty acid oxidation defects, and correction of energy deficit. And there are, of course, some specific medications, both pharmacological as well as enzyme replacement therapy, which I will briefly touch upon. So again, principles of management, especially this is specifically in focus of fatty acid oxidation defects. So you decrease the accumulation of toxic metabolites. So you want to limit lipolysis, avoid prolonged fats, limit long chain triglycerides, provide adequate energy and supplement with MCT, and always have an emergency regimen for illness. And they need to have regular monitoring so that we prevent any deficiency of a low LCT diet as well. And obviously, special things, of course, we're talking about infections, fasting, exercise, but another one is general anesthesia. So to think about that as well when you think your patients might need a procedure. And I don't know how relevant cold weather is here, but that's another precipitant. So just a very brief summary. So we've looked at this cycle and I thought we're quite familiar. So we want to give a high carbohydrate diet, stop in fatty acid oxidation management. So we want to stop this. We want to get all the energy from here because this system is not working. And that's pretty much what we would do in an acute management. Long-term management, again, we would limit lipid intake and we would look at trying to focus on a high carbohydrate intake. But of course, that comes with lots of problems. And we would optimize their nutrition by monitoring their essential fatty acids, because that's a big problem in management of fatty acid oxidation defects when you limit lipid intake. And how would you treat glycogen storage disorder? So there is a treatment for Pompe disease, and I know Dr. Bhatt has been doing it from the time I did fellowship with her. So that's well set up. And so that's one of the things that we would look at, which is ERT. And I'll briefly discuss about the new age enzyme replacement therapy that's been approved in the NHS and the US. I was involved in the trials that we were looking at for aval glucose today. So I'll give a brief summary about that at the end of the talk. So basically what we're trying to do is before exercise, we're trying and give them a bit of a carbohydrate-rich diet, especially if there's a block here. The higher the block, you can try this, but doesn't work anywhere else like here or here. So that doesn't work there. The other thing they've looked at is using triheptanoin, which is a C7 fatty acids. So basically it replenishes some of the products in the TCA cycle like propiononyl-CoA, and that helps in releasing more energy. So this is what they've been looking at, and I'll specifically go through some of the treatments that haven't worked very well on patients, but on theory they sound very promising. So obviously we mentioned MCT and additional treatment giving carnitine, because that's especially in carnitine transporter defects. So that's what we want to do. And riboflavin is for the multiple acyl CoA dehydrogenase deficiency, where we talked about the two kids, two opposite ends of the spectrum, one baby with dysmorphic features and elevated C14, as well as the older lady with recurrent rhabdomyolysis. So this was the one I wanted to quickly talk about, the phase 3 COMET trial. So this was a recent statement. So next Nexviazyme is a valglucosidase, and it has it is shown to prove better improvement in stabilization of respiratory function and mobility, and was well tolerated even for patients who had been switched from alglucosidase alpha, which is myozyme. Some of the new treatments that we're looking at, pharmacological therapy. So we're looking at sodium hydroxybutyrate. Again, it's a ketone body treatment. There are issues with it. It's costly. We're not really sure what dose might work. It can cause problems with alkalosis. So it's not ideal. And a lot of people get problems with it. So it's not really taken off with the patient population. Again, to use ketones when you're not producing enough ketones and bypass the whole oxidation pathway. They've looked at ACE inhibitors as well, and that is because some polymorphisms where you have problems with exercise tolerance. So they're looking again at patients with McArdle's to see if they can be helped. If they carry the polymorphism, then by giving ACE inhibitor, it helps improve exercise tolerance. They've also looked at resveratrol, which is present in red wine, again for McArdle's disease, and they're not very sure, but they think there may be antioxidant effects, and fibrates as PPAR agonists to look at, again, GSTs, predominantly McArdle's. There are some alternative treatments that have been looking at gene transcription, GST aminoglycosides, which help with gene transcription, and valproic acid, but both have not been shown to have much impact on the disorders. That was quite a brief run through. I thought, let me not make it very, very tedious. Any questions?
So Gauri, before you get asked any questions, I wanted to first of all say thank you. That's a complicated thing to cover. But more importantly, at several points, and most of the audience is from the neurology background, how often would you have to resort to muscle biopsy as versus direct genetic testing? And what sort of experience would you have with that?
So the experience,
like your CPT2 deficiency, which may have a normal muscle biopsy.
Yeah.
Is it?
So if you've got an abnormal carnitine profile and we picked it up when they were unwell, then it makes sense directly to go for genetics. But the conundrums are usually when they present with these symptoms, the older patients, you're not really sure. We've not gotten a informative carnitine profile or a urine organic acid. So those are the patients that we would, in all the fatty acid oxidation defects, the skin fibroblast would be first port of call, because we can do fatty acid oxidation flux studies, and muscle biopsy, not as much.
So the second thing, before we open it up for questions, I wanted to say is you spoke briefly about avalglucosidase, the new generation enzyme replacement therapy for Pompe disease. So it is approved now here in India, and slowly patients are being shifted from regular ERT onto avalglucosidase with some limitations. So just wanted people to know that it is becoming available, and it's in the last 6 months that this has become possible.
Yeah, that was excellent. So that's what I wanted to ask you, whether, we're doing any more enzyme for if that happened, because I think we had the discussion a long time back about whether we're doing GAA activity on DBS or not, or whether that would be available, or is that something available, or is on the
So
pipeline?
the algorithm that we follow in a suspected case of either infantile or non-infantile Pompe disease is to do a dry blood spot, which thankfully it's supported by companies, and it's completely free of cost for the index suspected case. So just need to point out that DBS is not always foolproof, and it needs to be, if you strongly clinically suspected, it would still need to be repeated or gone directly onto mutation studies if you're getting a sort of false negative testing. But that is available, and that's the sequence in which everybody is following the Pompe suspected cases. Yeah. So does anybody have any questions? It doesn't look like there's anything in the chat box yet.
I think you might have to lead the questions because the topic, Dr. Gauri, you made it sound so simple, but when you use even GAA, that's not something that comes very simply. We have a mixed audience here. We also have some physiotherapists, our neuromuscular physiotherapists who have attended. So that's a good point. I remember making a blunder with one of the, what we presumed was an LOPD, metabolic, and ultimately, like you said, mimic it, because Dr. Meenakshi, this was a patient that I discussed with you. It was a youngster who was athletic and then who became weaker, proximal weakness, and his EMG was for me, the EMG was evocative. Dr. Radhika was the one who did the EMG, was evocative of Pompe. So we did dried blood spot, and the dried blood spot showed reduced enzymes, low reduced, but it was reduced. But his genetics came out to be dysferlin.
So, okay. Yeah, it just says that you try and keep your mind open. So there are a couple of questions, and I thought I'll just read it out from the chat box, if that's okay. It said that there are some doubts about when do you plan neurophysiology after rhabdomyolysis? That's the first part. Do you want to answer it bit by bit, and then we can go on to the next one, Gauri?
So I think, I mean, with the rhabdomyolysis, before I would do anything else, I would go down the whole pathway with rhabdomyolysis. You've got a raised CK. I want to ask you a counter question. How many of this presumed, so you've got rhabdomyolysis, and if you say it's myositis, how quickly do you get EMG done for your presumed myositis?
So that's part of the question, as the ictal EMG would be difficult to interpret for myotonia. So that was part and parcel of the first question.
Okay, so basically with rhabdomyolysis, my first port of contact, if your CK is more, so I would look at the CK. If your CK is anywhere above 10,000, I would, and if there's a history of having problems with being unwell with viral infection, not eating and drinking too well, and or there's consanguinity, I'd rather you collect urine organic acid with an acyl carnitine profile first before you subject them to doing an EMG. It's not very informative with rhabdomyolysis in metabolic myopathies. So that would be my first port of contact. I'm not a big fan of EMG interpretation with rhabdomyolysis. I don't know what the neurologists feel about it. But if you came to me with rhabdomyolysis, exercise intolerance, cramps, pain, stiffness, my first port of contact or first port of investigation would not be electrophysiology. But I think that would be something that the neurologist would do in any case, but it's not very informative from a metabolic myopathy point of view.
So this one, may I ask something, Dr. Meenakshi?
What's that, sorry?
May I add something here?
Yes, please.
So this one, I think I should ask Dr. Umesh to answer, because he is the neurophysiology expert here on the panel. And one of the things that we stand by when we are doing Pompe disease is the myotonia in the paraspinal. And that's what fooled us with the metabolic myopathy, that dysferlin, which had the myotonia. But I
It's
guess
also the CK level for us. So if, with our fatty acid oxidation defects, you would not get a CK less than 20,000, or even, that would be how they would present if they're unwell with rhabdomyolysis.
okay. So Dr. Umesh, would you like to comment, Dr. Umesh?
Regarding what, Anne?
Regarding the rhabdomyolysis and the timing for EMG, and the fact that it can be confusing with the myotonia being present in other situations where it is not normally present.
Myotonia is seen with Pompe, infantile Pompe. We might see myotonia many times, but the clinical history, like a myopathic child, sick looking with some amount of maybe cardiac disease, and you can pick it up. But myotonia is seen with Pompe. I have seen many times. I don't have much experience with adolescent or adult Pompe for EMG. Infantile Pompe I have done.
We have seen it. Dr. Radhika also will be saying that we saw it with even adult Pompe. But the thing is, we got fooled with the dysperlin which had paraspinal myotonia.
Okay, so I think the last resort would still be genetic testing in such doubtful cases if you aren't getting to a thing, because I think obviously you're looking for an opportunity to treat if there's a treatable disease, and that probably is the differentiation. There's a second part to this question, and it said, would you evaluate young people who come with one episode provoked rhabdomyolysis after exertion as a metabolic myopathy?
Yes.
Or what would be the red flags?
Yes, if they've come with a CK more than 10,000, then I would do a workup for metabolic myopathy. That's without a doubt. Obviously, I'm not sure how expensive the genetic testing will be, whether we have a rhabdomyolysis panel here. And of course, doing a rhabdomyolysis panel, unless it includes all the pseudo-metabolic mimics, it won't make a lot of sense. But that would be the sort of first port of call if I was sitting in a metabolic muscle clinic, would be to investigate the rhabdomyolysis and also take consent for genetics to do a rhabdomyolysis panel. I understand that's probably not how things will be done here, but I would definitely investigate any CK that's more than 10,000.
So may I say something, Gauri? You've been referring to these panels of genetic testing, and I think pretty much in the Indian scenario, whichever lab you prefer to test with, I think most of the labs encourage and are very affordable for exome sequencing, increasingly whole exome. So it's not that difficult to, rather than do panels. Panels are almost as, if not more expensive to do.
Yeah, that's what I sort of came to know, because I'm so used to doing panels, because obviously we're not thinking about costing. But yes, I would investigate. And if genetic testing is available, we should do genetic testing.
So may I ask something about genetic testing? Obviously, when you do panels, when you do exome sequencing, you're not likely to pick up copy number variations as easily. So I think there must be some genes or some medical conditions, for example, the Beckers and the Duchenne's, in which you actually have much more copy number variations rather than having point or single mutations. So are there any other genes in your metabolic myopathies which you would need to highlight that for?
Definitely for MADD and also for CPT2 sometimes. So MADD is riboflavin-dependent medium acyl-CoA dehydrogenase deficiency. So those are the specific conditions we definitely ask for CNBs, because very often we don't get a mutation. And we have had copy number variations in these conditions. And also we prefer long-range PCR for suspected mitochondrial metabolic myopathy, in addition to doing the genomes, the mitochondrial genomes. So those are the two things that specifically in genetics that we would ask for in metabolic myopathy.
Thank you. Anybody with any other questions? I think there's a question here which says that how to, I don't know the name of the person who's asking it, this is Redmi Note 9. How do you suspect a metabolic myopathy in a case of provisionally diagnosed viral myositis?
So a very high CK on initial presentation and if it's seronegative, and if you've established some sort of a waxing waning pattern or some triggers or precipitating factors, all of that would trigger metabolic myopathy in a case of seronegative viral myositis, more specifically. And also if there's consanguinity. So I think we're a very endogamous population anyway. So I think we're probably not picking up a lot of metabolic myopathies. And I think we should, because there is treatment for quite a few of them, and they can be managed quite well with diet and having an acute emergency regimen when they're unwell. And they tend to do really well if they're managed, if they're picked up quite early. So I think we need to have a lower threshold for testing, especially when you see a really high CK on first presentation with, myalgia, a bit of or exercise-induced pain or stiffness. I think those would be definitely worth picking up early.
So also because you emphasize the various types of glycogen storage disorders, specifically type 3, type 5, type 7, and in your algorithm chart, there was type 9 also mentioned. So in all of these that have got muscle presentations, have you had experience with treating them with, you did say dietary management, but do you use the uncooked cornstarch, and does it have an impact?
So yes, so
the muscle symptoms?
the younger ones with the sort of the hepatic and the myopathic form, we do use uncooked cornstarch. But for the older ones, no. Ketogenic diet has been trialed, but it's quite challenging. And ketogenic diet was trialed predominantly for McArdles, and our patients were older, and they were very resistant to changing their diet because we had additional problems with high cholesterol levels to begin with. So diet has been quite challenging with glycogen storage disorders. A lot of places have looked, especially US. I think Weinstein's group has looked at ketone bodies and really pushed that for a while, but that didn't seem to work at all, and it's very costly and caused alkalosis. So that was a big problem as well. So diet is still in the gray area for glycogen storage disorder. But what has worked better is strength training, improving exercise tolerance by slowly building up strength. Those things have helped because we know the high intensity exercise sort of precipitate or make are problematic for glycogen storage disorder. So the idea was low intense or doing strength training. So that has helped quite a few patients.
Okay, good. So I also wanted to say you also talked about hemolytic anemia as a presenting factor.
Yeah. So especially with phosphofructokinase deficiency, when you're looking at a person who's come with rhabdomyolysis with hemolytic anemia, think GST. So that would be definitely something that should ring an alarm bell. And
will that resolve alongside conservative management of the GST related symptoms?
So it does. Interestingly, that's a very good question that we don't understand why it all resolves, but better management, exercise training seems to help hemolytic anemia as well.
Okay. So does anybody else have any other questions? And do you want to say something here? Because this is a complicated topic. And for people that have experience with handling cases, it's much easier to know the loopholes or the type of troubles you'd run into. But I think just that approach was really good, the way you presented it, Gauri, especially with segregating the carbohydrate and the lipid approaches. So, yeah. So is there any other issues that people want to comment on or discuss?
So it would be basically the way you are approaching, you and Dr. Bhatt, Dr. Meenakshi, when you approach the problem, because you're seeing a different end of the spectrum than we do. And oftentimes, so we approach it differently, and we sometimes get it wrong, sometimes get it right. We each have our strengths. So that's why it would be nice, because many of us, like say, many of the people here, Dr. Arijit, Dr. Umesh, Dr. Nalini, all of these people, all of us see these things. So it resonates. So EMG is a big tool for us, but we are also, it warns us of when to be wary about it.
Sure.
So that
and I think what Dr. Gauri was highlighting is that she seems to feel that the CK values seem to be a very good differentiating factor towards a clinical approach. Am I right, Dr. Gauri?
Yeah, and we've seen that very classically. Obviously, the younger ones, they present catastrophically. So you're no doubt with trying to get the diagnosis sorted, especially with the fatty acid oxidation defects. But the older patients, I'm not talking about GST, I'm talking only about fatty acid oxidation defects within the myopathies. The presentation there is usually the exercise-induced low intensity, where they have rhabdomyolysis, pigmenturia, trigger factors, precipitants. Those ones definitely, the CK is much, much higher. Because even if you look at the muscle energetics, the way you break down muscle, because you're in a sustained effort, you're not able to utilize free fatty acids. You start breaking down your muscles, so your CK goes up quite quickly, and it's very dramatic.
So I think that's possibly this end of the spectrum, Dr. Ann, to see that, if you have in the conservative ways, you don't do invasive testing before you do something that can be easier to access and answer. Obviously, you cannot bypass the biochemical values, because in this day and age, we still get variants of uncertain significance, and that is a whole other set of, do you label it as an answer or do you not?
So
but just a quick point. So if you see such a high CK while you're investigating, irrespective, start them on riboflavin, pyridoxine, CoQ, and measure the total carnitine before you start carnitine, or at least do a ECG to rule out long QT effects, because you don't want to give carnitine in a long chain fatty acid oxidation defect. So that's really important that these things are done, but definitely CoQ, riboflavin, pyridoxal, those things you can definitely start off.
So on that point, sorry.
Please go ahead.
No, it's okay. I was just being a filler.
No, I was just going to say also, Gauri mentioned HELP syndrome in mothers that were expecting babies with probably these, the VL CHADs and things like that. So I think that it's important to know that from pregnancy, you can start suspecting clinically, or at least being aware that you have to look out for certain things in a country which does not have widespread newborn screening. It's so important to look at the more severe forms that present at birth.
So that's on one side. On the other side, we pride a lot on ourselves as a country of clinicians who pick up science. So interestingly today, we saw an infantile tremor syndrome, which we have plenty of series. Was diagnosed. The child is now 11, 12. And this is a child that was diagnosed at 11 years of age with infantile tremor. And ultimately, it turned out to be one of the the cobalamin pathway disorders, genetically proven. But
so what are you trying to say, Anne?
I'm trying to say is that we usually get away with descriptions and we don't dig enough.
Okay. Yeah, so I think I'm sure all your audience will agree that what we label as infantile tremor seems to be quite common if you look hard enough. And many of them respond to the B12 pathway derivatives if you are going to treat them. It does reverse symptoms, and it is good to do a background genetic testing if affordable.
Yeah. So in the context of your hyper-CKemia, I wanted to just put one scenario that we had. We recently had a difficult child who had rhabdomyolysis, who had very high CPK, and then was not weak, then became suddenly weak at the age of 2 or 3, 2.5, something like that, post-viral illness. Initially thought of viral, was triggered by viral, but then genetics was done, and the genetics showed a dystrophin gene mutation, but it was an in-frame mutation. But the child was disproportionately weak. And then ultimately, we were not sure. We gave steroids. We were not sure. So this was a referral from another pediatric neurologist, a good pediatric neurologist, family from Delhi. Then they referred. They gave the child responded to steroids, but again had 3 rhabdomyolysis and deteriorated further and further. By the time it was 5 years, it looked like 4.5, 5 years, he was much more weaker than a normal DMD, the DMD at that age. And we were trying to phenotype and histiotype him along with his genotype. And ultimately, what we found was that his histiotype was that he was a Becker. He had well-preserved dystrophin 1 and 2, and only 3 was patchily present. And the initial primary doctor, who was still taking care of him, realized that the next rhabdomyolysis, he sort of he prevented with exertion. It was the climbing of the stairs that triggered it. And ultimately, it turned out to be Becker, and he settled with the rhabdomyolysis settling and us preventing another rhabdomyolysis. And so we were able to take off the steroids. So this was just a very convoluted journey that we had with rhabdomyolysis. We don't know in what point we are reaching, no, to them.
How
Have
high
you
was
had
the
such
CK,
experiences?
Anne?
I'm sorry.
How high was
Oh,
the
it was
CK?
40,000. 40,000. 40,000.
So-
40,000.
So I'd like to say something. We spoke briefly
Uh-huh.
about our endogamous and our consanguineous populations, and we are finding it at least between 5 and 8% of our children that we investigate with exome sequencing may have a dual diagnosis, multiple diagnoses. So I don't think you can stuff all features into one diagnosis in all situations. If
Yeah, I was
see
gonna.
Which is what
outliers,
we
they
did
may
a
be
whole
dual.
exome. We did.
Yeah.
Yeah, I was going to say the exact thing, same thing as Dr. Bhatt was saying, because I would feel uncomfortable with that CK, not also investigating very clearly. Sometimes, we've had problems with MADD, where we found only one mutation, or it's a deep intronic mutation or a copy number variation, but the skin fibroblasts are diagnostic of MADD and responsive to riboflavin. So that's why I would encourage always to make sure that we're ticked all the boxes.
Yeah.
So, which is
So I
why
think
we were
if
very
only a
suspicious of
small
this child.
fraction, only a small fraction of the children will be real outliers to your clinical symptomatology if you have an algorithm. And those are worth investigating further for an additional diagnosis, which may be causing secondary or multiple features. So I think that's something, because your child doesn't sound like a clear-cut Becker at any case. Would you agree?
So, which is
Sorry?
which I agree, which is why he was sent for a second opinion from a well-qualified pediatric neurologist. And we did, which is why we did the muscle histopathology in the second place. And we could
Sure.
not find any other oil redo, nothing we found other than this. And then ultimately he just went back to normal. But it took 2 years to get back to normal and not have a trigger. And the whole exome was done with centrogene because of this. And I couldn't figure out anything else. We did metabolic, some basic metabolic workup. I didn't do anything extensive. I just did a tandem mass. We didn't do anything more. All we did was whole exome. You have one more question, Dr. Meenakshi, in there.
I'm just trying to see if the new questions coming up. So second wind phenomena and out of wind phenomena, pathophysiology of this, could you please briefly explain how it works? So I think, Gauri, if you showed that initial graph of energy supply, that
Let me
will probably
share my
explain this.
screen again. Just bear with me a second. I'm just trying to reshare the screen. I don't know, I seem to be not
It's
very
just saying
efficient with it.
it's all right.
Just bear with me a
Yeah.
second. Okay. Can you see this now?
It's about to come. Yeah, you can see.
So basically what happens is it's an adaptation process. So when we're looking at the duration of exercise, what we're doing is the first half, you're having anaerobic glycolysis, and then you have sustained its aerobic metabolism. So what happens in GSTs particularly, or rather McArdle's, is when they start exercising, they suddenly have loads of cramp within 15 minutes. And that's basically around here. So if you see, this is pretty much where the FFA or free fatty acid starts kicking in. So this is where we see that they have a significant problem going into 15 minutes of exercise. They cramp up and then they adapt because already they're doing all of this exercise. The cardiac output is high. So they get more blood supply. And instead of anaerobic glycolysis, they go into fatty acid oxidation. So, and that's not a problem for them. So they have free fatty acids. So then they feel a bit better. And that's immediately after that, they start wanting to exercise again. And this is demonstrated very well when we do the exercise test on them. So we get them on a bike and we get them to do exercise on that really fast. And you can demonstrate it really well. This is exactly what happens. You time it. So you start timing from the time they get onto the bike, and you increase resistance within the first 2 minutes. And then they start doing like an uphill cycling test. And within 15 minutes, they just get terrible muscle cramps and pain, and they stop. And the adaptation is quite quick. And then they suddenly feel better because of increased cardiac output. They have more blood supply going in, and fatty acid oxidation kicks in. And that's when they start using free fatty acids, and they start becoming better up after the adaptive phase. And then they continue exercising. So that's the second wind phenomenon you see in McArdle's.
Okay, I think that's it. There are no more questions here. So, Anne, if there are, I think because it was such a succinct talk, I don't think there's much left to discuss unless somebody else has any cases.
I really tried not to get involved with GST because that's a completely different, you need a separate talk for that, including Pompe disease, because so many things are happening. So I thought I'd just keep it brief in terms of when to suspect and, the fact that we can treat quite a few of those things.
Yeah, just to say for the late onset Pompe disease, and we've published a pan-India series that have either been treated or not treated. And generally we find that cardiac involvement is very low, unlike the infantile Pompe disease. So just because it came up in the discussion slightly about cardiac manifestations, but the late onset Pompe disease has much less cardiac involvement in all situations. So it is a difficult field, you keep learning with Pompey's things. And we've not had although we've been trying to treat for a very long time. With the infantiles, we haven't done as well as with the slightly later onset, atypical infantile and late onset has been better.
Yeah, which is pretty similar to the experience there as well. So LOPD, no cardiomyopathy, they do plateau over a period of time with the myozyme. But a valve glucosidase, I was still in the early bits of collecting data in terms of functional motor outcomes. But it seemed that there was a bit of a change in drug effect as well. So lots of them have better patient-reported outcomes.
Yeah. So do we stop here, Anne? Would you want to?
Yeah, I would like to say thank you to ORDI at first, Dr. Meenakshi Bhatt, for being present here and moderating. And I'm sorry if it's an informal meeting, so sorry I butted in between. And
No,
thank you, Dr. Gauri.
That you've been there. Yeah, and thanks, Gauri. That was very nice.
Thank you, ORDI, and thank you to
all of you. And
all of you
thank
who
you for
attended.
having me, and thank you for listening for so long, because this is quite a challenging thing because of the biochemistry sometimes, but hope it was a little
more
simpler.
clear.
Yeah. Thank you.
It was more clear. Thank you.
Good night.
Good
to
night.
all. Yeah.
Good night. Good night.
Bye-bye.
Bye.
So that's Dr. Pawan there.